whether it's 4 or 6, you do maintenance considerations in this setting?
Yeah, we try to do maintenance. Right now there isn't.
In squamous patients?
Yeah,
So,
yeah.
Right, so in squamous, now if, again, necitumumab, although not highly used, is an obvious maintenance situation. Do we proactively use switch maintenance in squamous? No. Some of the data I've seen with nab-paclitaxel as a continuation looks very nice as well, and again speaks to the tolerability.
And there is an ongoing phase 3 trial in squames looking specifically at maintenance after 4 cycles of continuing the nab-paclitaxel. So that'll be a good, and we'll get to erlotinib as a maintenance a little bit further down the line here. But Ed's comment there is that I think that the side effect profile of nab-paclitaxel does make it somewhat amenable to more chronic administration. So maybe in an era where we really don't have a lot of good options for maintenance in the squamous population, that this will be an advance in this setting.
And I think to Tracy's point earlier, I mean, we kind of forget about that Phidias study way back when, where they used docetaxel, and they were able to complete 6 maintenance cycles of docetaxel, which is, if any of us tried to do that today, I think we would view that as something very arduous, to say the least.
Yeah, but there is some data with the gemcitabine. If you happen to be a gemcitabine, there is some continuation.
Progression-free survival is better if you go to
yeah.
gemcitabine. I mean, there have been some hints of overall survival benefit, but not consistent.
But we would argue again that gem is a drug that could be given for a longer period of time. Ed brought it up. I'm going to go back to David Jackman. He brought up the issue of necitumumab, and obviously EGFR monoclonal antibodies have had a sordid past in this disease. You know, we had a positive FLEX trial years ago that never gained FDA approval. We won't discuss why, but we had kind of the son of cetuximab, which is necitumumab, the fully humanized monoclonal antibody. And in the Squire trial, it showed an overall survival advantage and gained FDA approval. Your thoughts on that trial?
Yeah, so I think it's a wonderful example of thinking how we as oncologists need to ask ourselves not just can we, but should we? Is this clinically meaningful? So did it improve survival? The answer is yeah, it did. It improved overall and progression-free survival, both by about a month. It improved overall survival by about a month and a half. It didn't really improve progression-free survival or response rate in any clinically meaningful way. And so with that, I think what's our bar for how much of an improvement is worth the additional toxicity, and in this day and age, the additional cost. And so for us at our institution, we have not made necitumumab part of our everyday practice.
Others thoughts?
One of the issues also was it was with cisplatin. And so, that's a tougher sell in the US to use that combination. And because the efficacy margins were not so robust, one doesn't feel comfortable just substituting out carboplatin in that situation. At least I don't.
There's a paucity of data with regard to that. So I do think that the cisgem or the link to cisgem does create. But in that patient that's robust and can take cisgem, I think it's it's an option that I consider, even though it was not. I would not say it would be an option that I would consider in every squamous patient. It's had an interesting NCCN. Do you have any NCCN members here?
I'm a member, though I'm not on the non-small cell panel specifically.
Okay, all right. But an interesting NCCN journey where initially it was a category 3, getting back to I think it was probably the first example, at least in lung cancer, where the NCCN kind of made a value judgment, right? And my understanding is it's no longer included as part of the NCCN guidelines.
I looked, it was category 3.
But it was a category 3.
Right. So they had done a cost analysis on that before it was even commercially available, and if it were to maintain a value of $200,000 per quality adjusted life year, the price per cycle would have had to have been $1,300. Well, they ended up pricing it at $8,000 per cycle.
Yeah, that's...
To me, the greatest point of passion in this whole conversation is the cis versus carboplatin question. We may all be a little bit bored by it because it's nothing new, but our patients are not. From a quality of life standpoint, I think there is a very real difference between the agents favoring carboplatin.
Have the 4 panel members used necitumumab outside of a clinical trial in an individual patient?
I have not.
No, but I used to use cetuximab,
Yeah.
And I do think there were some people who really benefited, and I think we do need to try to figure this out. For cetuximab, it looked like the H score might be the predictive factor, which was a way of scoring immunohistochemistry for EGFR. But then that did not, that in the Squire study, that was not actually predictive. But then when they did another analysis where it was just straight up EGFR immunohistochemistry, which applied to 95% of the patients on the study, and just did that, they got the hazard ratio down from 0.84 to 0.79. So it was able to enhance the benefit a little bit, but still not
by
a great
excluding
deal.
5% of the patients, and doing that. And then there's a subsequent analysis looking at, we're back to Fred Hirsch's favorite subject, EGFR fish, and their analysis of the SWOG trial. I forget the number of the SWOG trial.
0342.
Yeah, the plus or minus cetuximab, the fish analysis there, as well as the fish analysis from the Squire trial. Necitumab, I think, is one of those drugs that needs a biomarker. I mean, if you could find the minority of patients, like PD-L1, right? If you find those patients, it's helpful. We just haven't been able to refine that, but maybe you could argue haven't done the right studies to do that either.
I mean,
Dave,
sorry.
Yeah, no, I just wanted to get back to your point, because I completely agree. We, as oncologists, have to kind of begin to tackle the value-based issues. My only issue with that is, why are we separating out necitumab? I would argue that ramucirumab and a number of other, maybe Bev. I mean, what's the number we're going to say, this is too expensive unless prices come down? It's not on the pathway or like that. So that would be my only comment.
No, you're absolutely right. And I think we are just barely scratching the surface at this. And even when we try to make value judgments, oftentimes we're making it based on drug acquisition costs. And really, we need to take into consideration the entire cost of care. Maybe a drug's a little bit more expensive, but if there are fewer toxicities, fewer hospitalizations, that's going to factor in. So we need to start doing this as a community, and we need pharma to take a role in this as well. We need to capture this data when they're running the trials.
Well, I think we're going to be told that down the road. I think the time we can be proactive about it, which I think we should, but I think we're going to be told down the road, and I think that's difficult. Especially in this frontline setting of squam, as some of the other data comes out with immunotherapy of single agents, and maybe they don't look as robust as the PD-L1 positive group, but there's plenty of unselected trials being done. The question would be, gosh, would you give a cis-gem Nesi combination versus a single agent unselected PD-1 inhibitor if it ends up getting positive that way and getting approved that way? And these are real things that could happen down the road. So I really think it's tough, and especially based on the data you presented with carbo and nab-paclitaxel, it was easy to find a substitute there because the survivals weren't that far off. The responses were actually better. Again, separate trials, but 42% that's a great response rate
For a doublet. Yeah.
Now, these may well become our concern in the future, right? The payers are pushing, and I think they will ultimately succeed to force practitioners to take on double-sided risk. I think we're not that far off from this. And it's going to switch from being a theoretical thought experiment like we're doing here into something that we really have to decide where the value is, whether we like it or not.
Yeah, and don't forget all the other stuff, the growth factors, the the PET scan versus CT scan, all that stuff's going to get lumped in, as Dave was saying, about the total cost of care. And so whoever invents that app, or maybe it already exists, that's what basically you're going to be doing with patients. And they'll have their own app too.